Then, sir, I think we will call Dr. Ragini for the next lecture. In the meantime, I think, Dr. Ibrarullah, I would like to tell you that CBD stones in our part of the world are slightly different from what you get from rest of India. We have slightly different because our problem is related to worms, roundworms. So
primary CBD stone, yeah.
So if
Hepatitis, I think Ragini is going to address that
touch that
aspect as well. Yeah.
In the meanwhile,
I think before that we can take up a question. This is for Monica, and there's a question from Sundar Shrestha that in our setting for recurrent multiple CBD stones. Monica, are you listening? For recurrent multiple CBD stone, choledochoduodenostomy versus hepaticojejunostomy, which you recommend?
choledochoduodenostomy is easier procedure if the duodenum is not stiff or edematous. If the duodenum is risky, like it may leak or something like that, then hepaticojejunostomy is a better procedure.
Fine.
I'd like to add something here, sir, regarding choosing a choledochoduodenostomy versus hepaticojejunostomy. Choledochoduodenostomy has a fairly high stricturing rate. So unless the CBD is at least 1.5 centimeters dilated, preferable not to do. At least CBD should be minimum 1. That's what the traditional teaching also says. If you have a CBD which is less than 1.5 centimeters, it's better to do a hepaticojejunostomy. And the sump syndrome, it's actually more due to the stricture that occurring in the choledochoduodenostomy rather than the food going in, actually. Because many times when you post choledochoduodenostomy, when you try to do an endoscopy or an MRC, you see that the anastomosis you do really contracts to about less than 1/3 of its size.
Dr. Monica it's a good answer. I think the selection of the procedure will depend upon the situation. If you want to operate fast, patient is not in a good condition, I think at that point of time, choledochoduodenostomy would be an ideal choice. Of course, you have to make the anastomosis. Okay, so that time, because
Less dilated bile duct, HJ stricture rate is less than choledochoduodenostomy.
definitely you have to have a dilated duct to do a good wide funnel shaped.
Yeah, for like even normal size duct.
If you operate by that diamond pattern, you make the proper, then definitely the stricture rates are certainly less, and it has to be wide. It has to be wide. That I will stress again.
So if there's an ampullary diverticulum and no stones are there, and dilated CBD is there, and a bit deranged LFT, so would you recommend the bypass or just leave it as post cholecystectomy, like intra with cholecystectomy?
No, I will not. But in such a situation, I like to exclude a periampullary tumor, first of all, if the CBD is that dilated and there are no stones. And having excluded that for whatever way I can, then I will not do anything for this. Drainage procedure.
Many of these patients who present with paraverted and diverticulums with dilated CBD, like Sir said, obviously do a CA99 and this thing, but many of these patients are elderly patients. So if the LFTs are deranged, some patients we've actually intervened. I mean, I'm sure Sir with more experience in ERCPs to do the sphincterotomy is technically difficult, right? Because it will be on the lip of the diverticulum. Then you can use a sort of a rendezvous procedure to do the sphincterotomy. Some patients do present with altered LFTs, but they're mostly very elderly patients. So they're not very fit for any this thing. And, there's age-related dilatation of the bile duct as well.
Yes. So since you have presented lab CBD, I'll ask, like this rendezvous procedure, is it really possible or is it real practical in our scenario in Indian setup? Because endoscopy people are not that free. I mean, they're time conscious and very they're just always in rush. So to call them in the OT and all.
I mean, we do a lot of rendezvous in post-transplant and that kind of scenarios. In the CBD stone scenario, like Sir was saying, I also don't prefer doing a CBD exploration in a normal size CBD because the transcystic, unless you have experience, you'll actually rupture the cystic duct or cystic CBD junction with those techniques. So what in that case, we've done very few, 4-5 cases. The only way we do is just through the cystic duct stump, we insert a guide wire and do a rendezvous. So, I mean, they have to make time.
I would just like to comment here, Dr. Ibrarullah, that how do we put a double DJ stent? Because you were concerned that it's a blind procedure. Basically, we are using the nephroscope and we are putting the guide wire through that through the papilla, then it becomes very easy, and we are sure that yes, it has passed. That is the one of the best ways we have found that we are safe, the patient is safe, and we are able to say with certainty that the stent has crossed. And most of these stents, within 6 to 8 weeks, they are passed spontaneously, around 50 to 60%, I would say. Only in rest of the cases, like Dr. Sometimes we have to resort to removing the stent by a simple endoscopy.
Yeah, that's true. I mean, another safer way is to use a longer stent and make sure that, I mean, a substantial amount of it has gone down so that in a way, it has gone across the papilla.
Yes.
I think
And
that
in fact, the tube that you have used, tube drainage, that is a lot easier because once we are putting in the stent, the upper end curls, and that is what makes it difficult to push it up as high as possible, and that gives a lot of issues, especially at the start of one's career. But once you have mastered the idea that you don't take out the guide wire till you have reached the end of your double J stent, and then you just push it in, it goes in very easily. We put the same stent, if we do not have a nephroscope, then we are using the suction catheter. We push it in through that, it remains very straight and it goes in very smoothly. That's one of the easiest ways we have found.
I read somewhere that
Ajit.
number 14 tube can allow a choledocoscope to enter in the post-op period. Is it true? I have no experience, so I'm asking.
Not T-tube, but like even recently we had a patient who came with the bile peritonitis. Patient had a lower CBD stricture and he came with bile. So emergency, we just did a T-tube. And through the T-tube, we can easily pass a guide wire. So we did through the T-tube, we passed a guide wire, and the ERCP guys, once he recovered about 4 weeks after the surgery, they've done a covered SEMS because for the leak, they put it there.
That's okay. That can
But scope,
help.
I don't think it's, you could probably go in with a spy scope.
Dr. Ragini. Dr. Ragini.
Yes, sir. Yes, sir. Yes, I'm here, sir. I've just mailed them I've just mailed them the attachment.
Okay.
So they'll be just getting the screen, sharing the screen here.
One more point I want to make about EHPV.
Dr. Fani.
Yeah.
Do you have any experience of doing laparoscopic CBD in situs inversus?
No, sir. No.
Oh, we have had 2 cases, in fact. And believe me, it's very difficult to reorientate yourself, put the 10 mm somewhere where it should not be. And if time permits, I would like to show that video. I'll take permission from Dr. Ibrarullah. Oh, yes, Dr. Ragini, please go ahead.
So at the outset, I'd like to thank Professor Kapoor for giving me an opportunity to be part of this wonderful learning initiative. So I'll be talking about primary CT stones and recurrent pyloric cholangitis. Change the slide. So CBD stones. So as we've been discussing, CBD stones can be those which form in the gallbladder, that's cholecystolithiasis, which then trickle into the bile duct. These are the secondary stones, and these are what are seen in more than 90% of patients. However, stones can form primarily within the bile duct or intrahepatically, and these are what are termed as primary CBD stones. They're usually pigment stones, the incidence being less than 5%. Next slide. Next slide. Thank you. So the previous slide, sorry. So the Saharia et al. In 1977, for the first time, laid down criteria for diagnosis of these primary common bile duct stones. So duration of more than 2 years beyond cholecystectomy, absence of a long cystic duct remnant, and a biliary stricture from the previous surgery were considered to be important for making a diagnosis. Along with that, the stones were of usually soft light brown stones or sludge or faceted stones. To this, what has been recently added is the absence of gallbladder or agenesis of gall. So the etiology, when it comes to, we'll be discussing this in detail when we talk about hepatolithiasis, but 2 factors are important. These are bacteremia and biliary stasis. Typically, they occur in settings when you have dilated bile ducts, like in elderly or those who have diverticula, and when you have recurrent or persistent infection. So when we come to hepatolithiasis, it is basically defined as the presence of gallstones in the bile peripheral to the confines of the right and the left ducts, with or without CBD stones and gallstones. 75% of these stones are going to be pigment stones, calcium bilirubinate stones. Primary is synonymous with recurrent pyogenic cholangitis. When you talk about secondary hepatolithiasis, you basically mean a situation where you have a clear-cut etiology. So this could be your congenital biliary malformations like your type 4A choledochal syndrome, where stones will occur in the dilated intrahepatic sacs of bile ducts. It could also be following a bilioenteric anastomotic stricture, whether it is following a bile duct injury or even when you do a hepaticogenoscopy for a type 1 choledochal cyst, there is stricture, dilation, stasis, infection, and stone formation. Similarly, in a patient with primary sclerosing cholangitis. Next, we come to recurrent pyogenic cholangitis, which is the topic of our discussion today. So this is characterized by intrabiliary pigment stone formation with the stricturing of the biliary tree and biliary obstruction with recurrent bouts of cholangitis. So this was first described in 1930 by Digby from Hong Kong, and since then has been termed variously as Oriental cholangiohepatitis, Hong Kong disease, Oriental infestation cholangitis, or hepatolithiasis. When we talk about the epidemiology of this disease, we see that the incidence overall seems to be slightly reducing. Globally, this is something that is seen more or less in Southeast Asia. So you get it in Hong Kong, parts of China, Japan, Korea, Taiwan. In our own country, we see more often of these cases like Professor Iqbal was talking about. We see patients coming from Kashmir, we see patients coming from West Bengal and Northeast. When it comes to the male-female preponderance, though some studies do state that it is equivalently distributed, most often we see there is a female preponderance of these of this disease. So the pathophysiology is, the mechanism is unclear, but we do know that what is required is infection, whether this occurs from portal sources, portal pyemia, or whether it occurs, the infection is brought by worms is not very clear. Also, what is seen is that contrary to the gallstones that are pigment stones that are seen in your gallbladder, when you get these intrahepatic stones, they have a much higher cholesterol content than your typical pigment stones. So there's also an alteration in the bile and the phospholipid metabolism there. And you also see that the left-sided ductal disease is much more common compared to right-sided disease. Again, reason not very clear, but postulated that the left side comes after the angulation, and this produces more spaces, making left side more susceptible to the stone disease. So etiology remains unknown in the vast majority of patients, but we do see patients primarily coming from the lower socioeconomic strata, more so from the rural backgrounds. So therefore, laying some emphasis on environmental factors having some contribution. Parasitic infestation has been something that keeps coming up again and again as one of the important factors in the etiology. So you have geographical clustering of these cases in areas where these parasites are predominant. So these would be your Clonorchis, Ophistochus, Fasciola, Ascariasis. Infections have been demonstrated in up to half the patients. However, what is interesting is that it's not all, because even in areas where your recurrent pyogenic cholangitis is endemic, there are areas where you do not have any parasitic infestations at all. The varying amount of infection demonstration could also be because either studies are not rigorously looking for it, or B, sometimes it's not the worm, it's not the live worm which is causing the problem. The worm has long back died, and therefore you do not demonstrate it any further. What is postulated is that this worm, which enters into the biliary tract, it produces intense biliary epithelial inflammation. Already these are patients who are malnourished, and the worm further causes malnourishment, reduces the immune response, making them more susceptible to cholangitis that occurs even from the translocating gut pathogens. So there appears to be some role of genetics also, because you are seeing geographical clustering. So geographical clustering could also be, apart from environmental or genetic risk. So you have a higher expression of certain specific HLA antigens in these patients. What is clear is that neither infection nor stasis is by itself sufficient, and there's probably a interplay of all these factors. So we see a very simple slide where you see the bacterial cholangitis and parasites combine to form infection. Infection leads to inflammation, that leads to cholestasis. The cycle repeats. It's a vicious cycle. It leads to stricture formation, and finally the pigment stones form. So the dead worms, their ova, all serve as nidus for the stone formation. The bacterial infection, the bacteria bring about the glucuronidases, they deconjugate the bilirubin gets laid down, the phospholipid metabolism changes, cholesterol crystallizes out, gets deposited, and the stones form. The stones then continue to serve as focus of infection. So what are the complications of these hepatoliths? So as the name suggests, they're going to have recurrent episodes of cholangitis. So patients could end up in septic shock. There is a definite mortality that is associated just because of the recurrent episodes of cholangitis in these patients. Recurrent episodes of cholangitis also lead on to secondary biliary cirrhosis. Up to 10% of patients may develop secondary biliary cirrhosis. And then the most dreaded complication is cholangiocarcinoma. It's reported in up to 7 to 8% of patients, and the fear looms large. Even after a hepatectomy, the risk of cholangiocarcinoma does not completely abate. So presentation, this is something that has been discussed yesterday also. The presentation is similar to that of CBD stones. So you could have abdominal pain on the right side, right hypochondrium because of the stones or the cholangitis, or it could be epigastric pain radiating to back because of pancreatitis, because of passage of stones. Cholangitis presenting with Charcot's, tired fever, abdominal pain and jaundice, or Raynaud's pented, septic shock and delirium is possible. A small proportion of patients may be actually incidentally diagnosed also because of the master health checkups. So if cholangiocarcinoma has, these patients may present with anorexia, weight loss, and even a mass. When patients develop secondary biliary cirrhosis, they can present with abdominal distension because of the free fluid, jaundice, bloating, etc. Or even episodes of upper GI bleed. So the diagnosis, so if you're going to do blood tests on patients who have come with cholangitis, you're going to find leukocytosis and deranged liver function tests with conjugated hyperbilirubinemia, transaminitis, elevated levels of alkaline phosphatase and gamma glutamyl transferase. Patients in pancreatitis may have elevated amylase and lipase. We do always tend stool for ova and cyst, but rarely does it yield anything. This could be possible because a vast majority of these patients are already treated with albendazole on the outpatient basis in their primary care settings. So if you look at imaging, ultrasound is the first line imaging for anybody who comes with symptoms of abdominal pain or jaundice, and though it can show us ductal dilation and stones in over 85 to 90%, it's a user-dependent investigation, provides limited information for treatment planning. So cholangiography is very important. So magnetic resonance cholangiography provides us with detailed evaluation of the biliary tree. Also, the advantage with an MRCP is that it can show you the anatomy both distal and proximal to your stricture. It can show you the exact number of stones, the location of stones, can raise suspicion of a mass. It can also give you some detail regarding the atrophy of the segments. So if we look at these images, these are images from our own patients. So this is a 45-year-old male who presented predominantly with left-sided disease. He was from Bengali, underwent a left lateral sectionectomy. Now this is a lady who came from northeast, from Arunachal. So she had, you can see disease in the left side of the liver as well as here in the right side. She had previous history of ERCP, and she had also had stones removed from the right anterior segment. So we did a left lateral sectionectomy along with stone clearance and drainage on the right side. This is another patient who had repeated episodes of ERCP and continued to have stones. Here you see stones both in the bile duct as well as in the right duct. And so she underwent CBD expiration, stone clearance, and from both the ducts with a hepatocystinostomy and an access loop. So computerized tomography. So this is a very useful adjunct to MRCP, and in patients who are being planned for surgery, I think it's imperative to get a CT scan done for a surgical planning. But otherwise, if you're planning for percutaneous techniques, MRCP would suffice. So it can give you almost all the information that MRCP provides you. It can show you dilated ducts. It can show you areas of the duct cutoff suggestive of stricture. Since most of these are pigment stones, they would be hyperdense and they can actually be seen. You could also see a mass. You can see atrophy of segments. You could see features suggestive of secondary biliary cirrhosis. And if you're going to plan a liver resection, then it provides you with a surgical roadmap of the vascular anatomy. Again, this imaging here from our own patient, you can see that the left lobe is completely atrophic. She had already undergone multiple sittings of ERCP, and you see good amount of pneumobilia here. This is imaging of the same patient here. It's the lower end of the bile duct. You can see something hyperdense here. So it's a dilated duct and with stones in the lower end also present. This is another patient who is actually from Kashmir. So the interesting thing is, though he doesn't appear to have a lobar atrophy, he had an intrahepatic stricture of the left duct. So therefore, he underwent a left hepatectomy, even though there was not much of an atrophy. And but those stones were not, it was not possible to tackle them with any other modality. So multiple classification systems have been proposed. So what is the need for these classification systems? As we have seen, the disease spectrum is very variable. You could have intrahepatic, extrahepatic strictures, atrophy, no stricture, dilation, no dilation. So in order to speak a common language to compare results, to find out which is probably the better technique, having a uniform classification helps. Unfortunately, we are far from there. Multiple classification systems have been proposed. This is one which is more recently published in 2012, and this is something that appeals to common sense and is is very useful in surgical planning. It is a Dong's classification. So here we have the type 1 stricture when you have localized disease. Type 2 is diffuse. So when you do not have any atrophy, it is A. When you have a segmental atrophy or stricture, it is B. And C is when you have secondary biliary cirrhosis. Additionally, extrahepatic stones with the presence of a normal, relaxed or strictured sphincter of Oddi are designated with the E. So type 1 and type 2B are amenable to a surgical resection. 2A is served with either an endoscopic stone clearance or with a hepatococyginostomy. For 2C, that is when you have secondary biliary cirrhosis, resection is out of bounds, and depending on select patients can undergo a drainage procedure. Otherwise, only liver transplantation is the option available for these patients. So this is another classification. In the interest of time, I would be skipping this and the next. The Tsunoda classification and Takada classification, these are older classification systems, all coming from Japan. So management, now this is one disease where a multidisciplinary management cannot be more emphasized. So you need a group of surgeons, gastroenterologists, intervention radiologists, and you have a critical care team to take care of the patient when he comes with acute cholangitis. They all need to be on the board as soon as the patient is first received. So the acute episode of cholangitis is treated with resuscitation. You start off with fluids, broad spectrum antibiotics. If the patient has had an intervention before, you may often have a culture available, so you could directly start off with culture-based antibiotics. Need to correct the electrolytes and coagulopathy. Tokyo guidelines for management of cholangitis are very much applicable here. When it comes to decompression, so here endoscopic or percutaneous techniques of decompression are indicated, but what is important to remember is that the segment of the liver which is driving the sepsis and the cholangitis needs to be recognized before you plan. The level of obstruction needs to be recognized, because all patients may not be amenable for endoscopic therapy if the strictures are intrahepatically located, and at times PTBD may score over endoscopic techniques in such patients. So the aim of definitive management is to prevent long-term complications in the form of cholangitis and secondary biliary cirrhosis and cholangiocarcinoma. So our treatment options are endoscopic, percutaneous, and surgery, and most often what is practiced is combination of all these. So what dictates is what is the location of your stone, what is the distribution of your stone, is your liver atrophic, where and all are your strictures. What is the expertise that is available for each segment of these options available to us? How many interventions has the patient undergone previously, and what are the interventions that the patient has already undergone? And then finally, what is the surgical risk? So if you have a very elderly patient, then they're better served with your percutaneous or endoscopic interventions. So non-surgical options are endoscopic options. So now this is something that is constantly growing day by day, every day. So you have ERCP with or without ESWL. What is coming up is spyglass with lithotripsy, and upper GI endoscopy. If you have done an access loop, you can use even upper GI endoscopy to clear your stones. So you can achieve clearance of stones. You can dilate your strictures with a spyglass. You can even take a biopsy of these if you have a doubt of cholangiocarcinoma. But what has to be remembered is the clearance rate is about 60 to 70% for endoscopic techniques, and they have a higher rate of recurrence, but they are better off when you have bilobar disease. Percutaneous techniques, you have a PTBD, and you can use PTBD to push the stones across and dilate your strictures. If you have done a surgery and you have a T-tube track, or you have placed a Hudson loop, either of these can be used by the radiologist to clear the stones. So when it comes to surgical management, the goal of surgery is A, you remove all the stones, B, you establish good biliary drainage, and C, you remove whatever atrophic liver is there, which can harbor bacteria, which can then serve as a nidus for recurrent infections. So what are the treatment options when you talk about surgery? So first and foremost, you have your drainage procedure, the time-tested hepatococyginostomy. Now this you can do as a site-to-site, retaining the continuity of your bile duct, which will then serve as, which will preserve your ability to do an ERCP in future if needed. Or you could resect and do an end-to-side this thing, especially if you suspect there's a stricture lower down, and that itself can potentiate your stone formation. Then you could choose to do an access loop. So this access loop could be a gastric access loop or a subcutaneous access loop. So access loop is very useful, especially if you're doing an end-to-side hepatococyginostomy, because it continues to retain access to the endoscopist or the radiologist to clear the stones from the retrograde fashion without going through the liver. Then you have the segmental resections. The segment would be decided upon the presence of stricture, atrophy, or the segment to which the liver disease is localized. And last surgical management, last resort, is your transplantation. So what are the indications for doing a surgery? So if you have disease that is restricted to one side to begin with. Second, if you obviously have a suspicion of a malignancy. Third thing is if your disease is refractory to any other form of management. So you have multiple ERCPs. Now, what is refractory is not clearly defined. It's in common practice, it basically is when the patient says enough is enough. Otherwise, it goes on and on. And then when you have atrophy of the segments, and when you have multiple stones that are causing stricture, which cannot be treated endoscopically. So again, choice of the procedure depends upon disease localization. So if it is localized to one segment, or you already have atrophy of that segment, then resection is a very good choice because it completely cures it. Then what is the response or amenability to other interventions that we have? So if you have bilobar disease, then sometimes you may just choose to do a drainage procedure and not try to resect. Then what is a parenchymal reserve? So you need to have a good parenchymal reserve before you choose to resect a segment, especially if there is no atrophy. And then if there is a suspicion of malignancy, then resection is the go-to treatment option. So these are results of surgery. So this is from data from our own country, from West Bengal, from PGIMR, published in HPB in 2016. So 94 patients, data over 10 years, 70% females, median age of 70 years. 1/3 had undergone ERCP. Disease was restricted to the left lobe in a half of the patients, and in 1/3 it was above. And atrophy was seen in another 1/3 of patients. Concomitant choledocholitis was seen in nearly 2/3, and cholelithiasis was seen in a fifth of patients. 6% of patients had associated portal hypertension. If we look at the surgical procedures performed, the hepatogenostomy or drainage procedure was the overwhelmingly most common procedure offered to more than half the patients. Left hepatectomy alone was offered to a fifth of patients, and left lateral segmentectomy to another 14%. And the rest of the procedures, that is hepatectomy with or without hepatogenostomy, were less than 5%. And if you look at the complications, so they had complications in a third of patients, but only one mortality, and most of the complications were less than Clavien Tinto 3A. They had retained stones in close to 18%, of which 6 were cleared endoscopically. They followed up 89 patients for close to 3 years, and stone recurrence was seen in 10%, of 3 of which required reoperations. And 2 mortalities, one because of cholangiocarcinoma and one because of sepsis. So this is another study which looked at the utility of hepatectomy when you already have bilobar disease. So this was published in Annals in 2010. So close to 136 patients. So when you have bilobar disease, the treatment options you have are A, you can just do a stone clearance and a hepatogenostomy. B, you can resect one side, especially if it is like if you have a left lateral segment or right posterior, you can resect one side and do drainage to the other side. The third option that you have in this situation is, as if it's amenable, you have right posterior and you have left lateral, resect both and drain the remaining liver. So they found that when they did bilateral hepatectomies, the stone clearance rates were 80% as compared to 65% when they did unilateral. When they added your endoscopic treatment methods post-operatively, that increased the stone clearance rates further and brought up the unilateral ones also to 80%. So they concluded that, and they had good long-term survival of over 95%. So they concluded that patients with bilobar amenable to bilateral hepatectomy and unilateral with the drainage of the other side is a viable treatment option. So laparoscopy is fast coming up, as especially for left-sided liver resection. So this is a systematic review and meta-analysis which showed that laparoscopic hepatectomy entailed left hepatectomy, to be specific, entailed lower blood loss, lower rates of intraoperative transfusion, fewer overall complications with similar rates of residual and recurrent stones, and was therefore found to be safe and effective in selected patients who have hepatolithiasis. So now a few words on liver transplantation. This is the last ditch resort. Very little data, small case series in patients who have secondary biliary cirrhosis or those who have got recurrent cholangitis with extensive bilobar stones. This is a technically challenging procedure because these are patients who have already undergone multiple operations, multiple interventions, multiple episodes of cholangitis, liver abscesses which have ruptured. Even hepatectomy in these patients is difficult even when they do not have secondary biliary cirrhosis. So once they develop bilirrhosis, these are all densely collateralized adhesions, and so even the bleeding can be an undoing in these recipient hepatectomies. And even in fact during the mobilization itself, there can be a flare up of sepsis, there can be bacteremia, and that itself can cause the patient to crash. So this is a slide that shows a few of the series of liver transplantation. So small numbers, but what it shows us this is something that is doable and probably the last ditch resort for patients who do not appear to have any other treatment option. So if you look at outcomes, this is a gist. It shows that most of your percutaneous treatment options have results ranging in 70 to 80% stone clearance rates, with recurrence rates upward of 30%. Whereas when it comes to surgical options, the clearance rates are closer to 90%, with recurrence rates of 10 to 20%. So this is an article which was published, which looked at the risk factors for long-term outcomes. So out of 260 patients, 175 were excluded who had either malignancy or mortality or cirrhosis, and out of 85 patients, they followed them up for close to 5 years. They found that 5% developed secondary biliary cirrhosis, 2% developed cholangiocarcinoma. Recurrent cholangitis occurred in 16%, probably because even though they were these did not present as cholangitis, and most of these were managed with percutaneous or endoscopic approaches, some only with antibiotics. Only one required reoperation. These are a combination of patients who have been treated with surgery or with percutaneous techniques, both, and they found that when it came to hepatobiliary complications, the complications occurred in close to 30% of patients who had residual stricture or residual stones, and residual strictures or stones were the only statistically significant factor for long-term poor outcomes in patients who have hepatolithiasis. So now this is a study that looks at practice patterns, how they have changed over the last 40 years. This is from Japan. So early on, surgery was the primary treatment modality, but as time passed, initially the percutaneous techniques took over, and currently it is ERCP. So ERCP increased from 0.2% in 98 to 22% in 2011. However, there is a higher rate of residual stone and recurrent stone after ERCP compared to surgery or even percutaneous techniques. But currently, non-surgical treatment is often performed as the first-line treatment for hepatolithiasis, and surgery is used when there is treatment failure. So now we come to the take-home message. So hepatolithiasis is a vexing problem. Stones tend to keep recurring. However, thankfully, with improvements in the social context and nutrition, the illness etiology not very common cases seems to be responsible. Patients typically present with recurrent episodes of cholangitis. Treatment options include endoscopic and percutaneous. In today's era, practically these are often the first-line treatment options that are being used. Surgery, though, does have better results. Surgical options being drainage, hepatectomy, and liver transplant. So, thank you. So, this is one picture of one of our patients who had hepatolithiasis, where we did a gastric access loop, and this is the stone that is being removed. These are the bile ducts that we can see, and this is through the stomach that they have gone in using an upper GI endoscope to retrieve the stone. Thank you so much.
Thank you, Dr. Ragini. Wonderful. And you people are doing a wonderful job with regard to liver transplant. Sir, your comments? Because this part of the topic is very close to us.
Agreed. I mean, this is common in Kashmir, but all the same, we also tend to see some, some cases here. In fact, that series was from West Bengal, 80 odd cases. We have seen about 6 cases in last 10 years in our center itself. And yesterday, in fact, we had a city meet where, the center, another from the medical college nearby, they presented 2 cases in last 1 year. So what I'm going to say that this is rare, yet not so rare. Once in a while, do get to see these patients in our clinical practice. Of course, may not be as much as what you people see in North India, I mean, in Kashmir and that area in particular. So I suppose you can make a better comment. Just a quick comment that, well, this is a difficult problem. But what I realized that if you have a resectable segment or that is the best treatment for this. Otherwise, these stones keep recurring or so difficult to clear, and they're almost at every nook and corner of the liver and every bile. I mean, smallest of the small bile ducts are all full of stones, so they're difficult to clear. So resection, if possible, as and when you have a resectable segment, it's better to go ahead and knock off that particular segment and manage the rest. Thank you.
Sir, with your permission, I would like to show you exactly what happens to these patients, how the worms are there. With your permission.
Yeah, please continue.
So we are a place where these worms are endemic, and this is what happens. This is how they are found in the CBD. You can see the stent just behind this worm. It's a live worm. Usually these do not cause OCH or these primary stones till they die. So this is one of the cases, and sometimes we have seen up to around 20 to 30 worms in the CBD, and patient was asymptomatic. So this is another case. Now this is totally situs inversus. You can see the stomach on the left side and the gallbladder on the right side. Again, our endoscopic friends could not remove the stones in this case. This is what I was referring earlier. This was very difficult because you have to reorient ourselves, and again there were stones in the CBD. Here you can't even differentiate where the gallbladder is and where the CBD is. So we just try to dissect it. You can see that there is no demarcation. So we made the opening, and now I just want to emphasize what the stent does. Sometimes the stent is the problem. Now the stones will be taken out and the stent is there, one of the stones. Now this is flushing and now the stent is there, but it's stuck. This is the problem. So it was with great difficulty. You can see what was causing it to get stuck. Then rest of the things. And this is our view from nephroscope. We used rigid nephroscope in these cases. There was certainly a big area where the stone was stuck. Now, most of the times we are faced with problems that we have stones, especially in the left side of the liver, because the left hepatic duct comes out at 90-degree angle, and that is one of the major issues why we have so many stones. And number two, the OCH that we find in Kashmir is slightly different from what is found in the Southeast Asia. Here there is less of stricturing of the bile ducts in the liver. There are more of stones and they are more confined towards the left side. We have till now done around 3 resections, but unfortunately in one of the patients we had an issues and we converted that. I just want to emphasize that if you're doing a hepatic resection for OCH, please remember the hepatic veins will not be at the normal place. They will be slightly more towards the hiatus. So be prepared. So you can see the portal vein here very nicely demonstrated. And we use simple suction irrigation cannula to great extent, to great results. And we try to dissect the CBD common bile duct grossly dilated. And I think you can understand that this is certainly going to be an anastomosis that will be wide. And for Ragini, Stigman's operation, there is an issue with that. The endoscopists find it very difficult to enter that loop. While as in a Hudson's loop, it is easier to go as compared to Stigman's operation. A vertical end to side Roux-en-Y hepatojejunostomy serves the best possible purpose presently with the advent of PTBD, because even if there are recurrent stones, then our radiologist friends are able to deal with it in a better fashion. Because to go into hepatojejunostomy, this is the clearance achieved, and now what we have done is that we have shifted our focus, as we saw earlier that the nephroscope, this ureteroscope is used. What we are now using is, I think we can skip this part. This is the part of the hepatojejunostomy. Now we are using this flexible cystoscope. This is a beautiful product. It can be used for 10 cases at one time. It's a mobile, video is attached to it, the screen is attached. We don't need the whole setup like we need in a cholangioscope or in a choledocoscope. And it's flexible. It can go right up. And what you can do is that you can put a laser fiber through it. If there are stones in the liver, you can lase them. And because there are 2 places, now you can see this is the clearance that has been achieved. And there are some, we'll go to the next. You can see the stent also that has been placed, and still it has not been that effective. Laser. And this is the laser, contact laser we are using. And by this, we are able to achieve near 100% clearance of the intrahepatic radicals, because it's a very small fiber. It can easily traverse through this flexible cystoscope. It costs around 60,000. Then we can dispose it off after 6 cases. Or we can use tri-prong, as Dr. Saab already said, that's a very strong thing. This is our experience with regard to OCH, hepatolithiasis, whatever you call it. And you can see that in Kashmir, this is a common recurring problem, and we have to face it almost on daily basis. Thank you very much. I hope these small videos have made it a little bit more clear what exactly is happening in our part of the world. Thank you, sir. Thank you for the time.
Thank you so much, sir. So just I could not get into the discussion because my video was uploading at that time. So I just have one question to to you all, do you primarily close the CBD even without a stent when you do a CBD exploration? It's a dilated CBD. So is
If
it
it's a
really?
dilate, yes. If
Because
the papilla is wide, if the
yeah,
papilla is wide,
because you put
we'll
in a
close it primarily
choledocoscope,
without stent.
we've done a choledocoscopy, we've ensured, we've gone into the duodenum, we have seen everything is cleared, we've gone up, we've seen everything is cleared. So because, I mean, that has been my practice, that I tend to directly close the CBD and not leave behind. And leaving behind a stent has another problem, that oftentimes if these people do not get it removed, the stent itself is a nidus for the recurrent stone formation. So
They
stent
forget the stent.
they forget
They
the
forget
stent.
the stent. So
They
it's
forget the
wiser
stent.
if you have put in a stent, please mention it in your operative note, plus on the discharge, plus make sure that the patient on the first visit comes back to you only and you tell him that you have to get this stent. It might move out on your own. We do see those patients, they come, hey, sir, what has passed with our stools? What is this? So around 50 to 60% pass, but 50 to 50% do not pass. So make sure that you tell the patient that you have a stent.
And I don't know if Dr. Funny is still
Yeah, I'm
with
here.
us, or Dr. Funny, I just happened to notice that the first video of CBD exploration that you showed, where you were cutting the CBD with your scissors, the incision was appearing to be
Yes.
horizontal.
Yes.
So any comment on that? Because I
Yes,
know
I
there is
mean,
data which says it doesn't really give. There's no difference whether you cut it horizontally or vertically.
basically, when you have a pretty wide CBD, you can cut it horizontally, because the horizontalization one is when you close, you don't narrow, and when you put your instruments across, manipulate it, the linear tear can extend. But we rarely get the opportunity. This vertical incision, transverse incision, we usually put when we have a single large stone which is swelled there, and we know that we have to only do that. That time we do it. And I totally agree with you that if you're sure about your clearance, there's no need to put the CBD stent. It's just a habit we do. It's a force of habit. That's all.
A safety feature,
That's it. That's it.
inbuilt
It's
safety
Just one,
feature.
Circuits
yeah,
are
one
always
comment.
safe to habit. Yes.
Yes,
Yeah,
sir.
that about that incision on the CBD. In fact, for a moment, that also made me cringe. That transverse incision over the CBD. I was wondering like how far is going on either side, but thankfully, it was just a small nick kind of a thing.
It's usually
But
very
the
dilated.
disadvantage is, vertical incision you can extend on any direction, depending on the requirement of the stone size. Whereas this transverse incision, I mean, you really can't go on either side. It's almost like transecting a CBD.
Very rare. Very rare.
So
That's what it is. Yeah.
that's one. And as regards stent, yes, you have a very clearly defined number of stone, one or two very clearly seen that you have very clearly removed as well. So you can pretty well do a primary closure. But all the same, it's always safer to, leave a stent inside. So that does the drainage. So your post-op, even if your suturing is not perfect, at least the stent would take care of that. So that's one reason I would like to stent all my patients as whenever I do a lab
With a
exploration.
simple tube. With a simple tube.
Yeah.
I have one question for Dr. Ragini. We don't have any very rare hepatolithiasis in India. Most of the patients, few come from Orissa and mostly from West Bengal. In West Bengal also, is it associated with parasites? Because I've never seen a patient with other than exclusively Kashmir kind of problem.
So actually, that's what I said. Ki whatever patients we have sent off for stool ovacyst, I've never gotten a positive result on any of these
I don't
patients.
think Kashmir disease is different from West Bengal disease, I guess.
Definitely. Kashmir disease is different. It's
But
because of the worms.
and Kashmir ascariasis has been documented, and like you have said, you showed us a video where you're getting the worm out. So those have been documented very well from there. But the patients that we receive from Northeast, so it's not just West Bengal, we receive from Sikkim,
Yes, yes.
Arunachal,
Assam,
and
exactly.
Assam also. So the entire belt of patients, and they tend to have strictures and they tend to have bilobar disease.
Yes.
So those patients we see, but I haven't actually gotten a positive result on any stool for ovacyst. It's more of a hypothesis that this could be happening also in these patients, because they may be mimicking, considering it's Northeast, they could be mimicking more of the Southeast Asian countries when it comes to
And-
their pathophysiology.
And Dr. Agni, there is a very good description of a paper from SKIMS, our other institute, in 2014. Dr. Fazal and his team had given a very clear briefing about how to manage these patients of specific OCH, the Kashmiri variant. It's a very good paper. I hope you go through it. Sir, before we conclude, I would like to thank
One just
all
quick
the
question from the
speakers.
audience. One quick question from the audience. I think we should take that. Is it advisable to pass Bake's dilator and dilate the lower end of CBD before doing choledochoduodenostomy? Can this prevent some syndrome? My answer is no, it's not required. If you're doing a choledochoduodenostomy, doing a good stoma, that itself should take care of the SUM syndrome in future. You don't have to do a Bake's dilatation on table to prevent that, because SUM syndrome does not happen in the immediate post-operative period. It's a long-term complication. So just dilating at that point in time with Bake's dilator is not really going to help or prevent the SUM syndrome in future.
Sir, should we wind up now? It's 9 o'clock.
Is there any question? If there are no questions from the panelists or from the audience, I suppose thank you all very much for a very good discussion and lively discussion on the choledocholectasis and its treatment, the various modalities. Thank you all so much. Thank you, Saleem. And thank you all the presenters. Thank you.
Thank you, everybody. Thank you, Fani. Thank you, Monica. Thank you, Dr. Ragini. Wonderful. And thank you, Dr. Kapoor, for inviting me to be part of this wonderful initiative, which is really going to benefit the students all our place. Thank you very much, sir.